Welcome back to StudyNeuro. In today's session, we'll focus on the relevant anatomy for the safe and effective use of the Mayfield Head Holder. This device provides rigid cranial fixation, but its safe application depends heavily on understanding the underlying anatomical structures. We'll review the thickness and strength of different skull regions, highlight safe zones for pin placement, and point out critical structures to avoid, including cranial sutures, venous sinuses, air cells, and superficial vessels and nerves. A clear grasp of this anatomy is essential not only for minimizing complications like fractures, hematomas, or nerve injury, but also for ensuring stability throughout delicate neurosurgical procedures. By the end of this video, you'll appreciate why anatomy is the foundation for both the safety and precision of Mayfield application. When applying the Mayfield Head Holder, it's important to understand the layers that the fixation pins must pass through before achieving firm anchorage in bone. First, the pins penetrate the skin and subcutaneous tissue. The skin of the scalp is highly vascular, and the subcutaneous tissue contains dense connective tissue that firmly binds vessels. This explains why even small lacerations or pin insertions may bleed significantly. Next, the pins pass through the scalp aponeurosis, also called the galea aponeurotica. This tough, fibrous sheet connects the frontalis and occipitalis muscles. It provides resistance during penetration and helps distribute tension across the scalp. Beneath this lies the loose areolar tissue, sometimes called the danger area of the scalp. It contains emissary veins that communicate with intracranial venous sinuses, creating a potential pathway for infection if hygiene is not strictly maintained during pin application. The next layer is the pericranium, or periosteum, which is tightly adhered to the outer surface of the skull. This layer is important because it provides the final soft tissue barrier before the pin reaches bone. Finally, the pin engages with the outer table of the skull, which serves as the true anchoring site. The skull's thickness varies depending on the region, so choosing an area with adequate bone thickness is essential to ensure stability while avoiding penetration into the diploi, or inner table, which could cause intracranial injury. Skin and subcutaneous tissue. The first barrier the Mayfield pin passes through is the skin and subcutaneous tissue. This layer is made up of the epidermis, dermis, and a variable amount of subcutaneous fat. It is both richly innervated and highly vascularized, which makes it extremely sensitive to pain and prone to brisk bleeding when injured. Clinically, this sensitivity has major implications. If the scalp is not infiltrated with local anesthetic, or if systemic anesthesia is too light, the patient may experience a powerful sympathetic response to pin insertion. This response typically presents as acute hypertension and tachycardia, and in vulnerable patients, it can also trigger arrhythmias or worsen intracranial hypertension. For this reason, proper local anesthetic infiltration at each pin site and good coordination with the anesthesia team are essential steps before the head holder is applied. The next layer traversed by the pin is the scalp aponeurosis, also called the galea aponeurotica. Structurally, this is a dense, fibrous sheet that connects the frontalis muscle anteriorly to the occipital muscle posteriorly. It essentially acts as a tough, tension-bearing layer that holds the scalp together. Functionally, the galea provides tensile strength and mechanical stability, and it helps distribute forces evenly across the scalp. This is why scalp lacerations that extend down to the galea tend to gape widely. They're being pulled apart by the opposing action of frontalis and occipitalis. From a surgical standpoint, this layer is important because when the Mayfield pin penetrates it, the operator often feels a distinct resistance. If the pen does not adequately pierce the glia and anchor securely into the underlying bone, there is a risk of skiving, where the pen slides across the surface instead of gripping firmly. Proper tightening, perpendicular pin placement, and ensuring penetration beyond this layer help avoid instability of the head fixation. The final and most critical layer traversed by the Mayfield pin is the outer table of the skull. Anatomically, the calvarium has a three-layered structure: the outer table, made of compact cortical bone; the diplo, which is cancellous bone containing venous channels; and the inner table, another thin cortical layer in close relation to the dura mater. The outer table serves as the true anchoring site for the Mayfield pins. Secure fixation is achieved when the pin penetrates just into this dense cortical bone, providing sufficient grip to immobilize the head. However, care must be taken to avoid advancing too far, because breaching into the diplo or even the inner table risks destabilization or serious complications. Clinically, excessive torque or poor pin placement can cause complications. In areas where the skull is particularly thinned, such as the temporal squama, the frontal sinus region, or in pediatric patients, the pin may crack or perforate the bone. This could result in linear fractures, pin site depression fractures, or even an epidural hematoma from injury to vessels within the diploic space. For this reason, the surgeon should always select safe, thick calvarial regions, commonly the parietal bones, and apply controlled, even pressure during tightening. Correct placement on the outer table is what ultimately ensures the rigid, stable fixation required for delicate neurosurgical procedures. Temporalis muscle. The temporalis muscle is a large, fan-shaped muscle that originates from the superior temporal line and converges onto the coronoid process of the mandible. It lies in the temporal fossa and overlies the temporal squama, which is one of the thinnest and most fragile parts of the skull. In the context of Mayfield pinning, this muscle has important implications. If a pin is placed through the thick belly of the temporalis, the surgeon may feel some resistance and mistakenly assume solid anchoring. However, the pin may actually be lodged in muscle tissue rather than cortical bone. This results in poor bone purchase and unstable fixation, which defeats the purpose of rigid cranial immobilization. Furthermore, pin insertion into this region risks hematoma formation within the muscle, leading to post-operative pain, swelling, and potential difficulty with jaw movement, since the temporalis plays a major role in mastication. For these reasons, it is critical to avoid thick, muscular regions when placing Mayfield pins. The surgeon should palpate the skull to confirm direct contact with bone before applying torque. Ideally, pins should be seated in the parietal region, where the bone is thicker, more uniform, and free from large muscular coverage. The frontal sinus is an air-filled cavity located within the frontal bone, just above the orbits. It has a thin posterior wall that separates it from the anterior cranial fossa and underlying dura, making it a critical structure to respect during cranial fixation. From the standpoint of Mayfield pin placement, the frontal sinus region poses significant hazards. If a pin is inadvertently driven into the sinus, several complications may occur. First, the breach can create a direct communication with the cranial cavity, resulting in CSF leak, which may manifest clinically as rhinorrhea. Second, the sinus can serve as a conduit for infection, raising the risk of meningitis or even intracranial abscess formation. Third, there is the possibility of tension pneumocephalus if air is forced into the cranial cavity through the sinus breach, especially under positive pressure ventilation. Because of these risks, the key teaching point is to avoid placing pins near the superior orbital rim or the midline of the frontal bone, where the frontal sinus is typically located. Anatomical variability is common, so the safest practice is to review preoperative imaging, especially CT scans, if there's any doubt about sinus boundaries. Sutures are fibrous joints that connect the bones of the skull. Major examples include the coronal, sagittal, lambdoid, and squamosal sutures. These joints allow for slight movement between skull bones and accommodate brain growth during childhood. In infants and young children, sutures are wider and not fully ossified, meaning the bones have not yet fused completely. This makes the area softer and more pliable compared to adult skulls. Pins rely on strong cortical bone for stable fixation. Placing a pin directly over a suture provides poor purchase because there is little to no cortical bone at these joints. In children, the softer suture regions increase the risk of skull fracture, pin penetration into the dura, or intracranial injury. Key point for safe practice: always avoid sutures when selecting pin sites. Use palpation to feel for bone ridges and avoid soft areas. Preoperative imaging, CT or X-ray, can help identify the exact location of sutures and confirm safe zones for pin placement. Takeaway: careful anatomical assessment of sutures is critical to prevent complications and ensure the stability of the Mayfield Head Holder during neurosurgical procedures. When we discuss the relevant nerve anatomy for Mayfield pin placement, several key sensory nerves of the scalp must be highlighted, as they are not only prone to injury, but can also trigger important reflexes. Let's start anteriorly. The supraorbital and supratrochlear nerves, branches of the ophthalmic division of the trigeminal nerve, emerge from the supraorbital notch or foramen and the medial orbit, respectively. They supply sensation to the forehead, anterior scalp, and upper eyelid. Injury to these nerves can lead to numbness or dysesthesia, and their stimulation during pinning may even trigger the trigeminal cardiac reflex. Moving laterally, the auriculotemporal nerve, a branch of the mandibular division of the trigeminal nerve, V3, ascends just anterior to the ear, closely accompanying the superficial temporal artery. It supplies a temporal region, auricle, and external auditory canal. A misplaced pin in this region can cause temporal numbness or neuropathic pain. Posteriorly, the greater occipital nerve arising from the dorsal ramus of C2 emerges between the atlas and axis, travels with the occipital artery, and pierces the muscles to reach the posterior scalp. It provides sensation to the occiput and posterior scalp. If injured, patients may develop posterior scalp numbness or even occipital neuralgia. Now, clinically, the most important phenomenon here is the trigeminal cardiac reflex. This is a parasympathetic reflex mediated via the vagus nerve that can be triggered when these trigeminal branches are stimulated during pin insertion. The pathway involves the afferent limb, sensory fibers of the trigeminal nerve, such as the supraorbital, supratrochlear, or auriculotemporal nerves, the central relay at the trigeminal sensory nucleus in the brainstem, and the afferent limb via the vagus nerve, leading to a sudden parasympathetic response. The result can be acute bradycardia, hypotension, arrhythmias, or even asystole during pin application. This is most likely to occur when anesthesia is inadequate. So, the key teaching point is: always ensure adequate depth of anesthesia and analgesia before pin placement, and avoid placing pins in areas where these nerves are particularly vulnerable. When placing Mayfield head holder pins, we must always keep in mind the major arterial structures of the scalp and skull, as injury to these vessels can lead to significant complications. Let's begin with the superficial temporal artery.
This is one of the terminal branches of the external carotid artery, and it ascends just anterior to the ear, crossing over the zygomatic arch before fanning out into the temporal scalp. Clinically, it is often palpable at the temple and travels alongside the auriculotemporal nerve. If a pin is placed too close to this artery, it can cause brisk bleeding or, in delayed cases, lead to a pseudoaneurysm or even an arteriovenous fistula. This may present as a pulsatile swelling near the pin site. Next, the middle meningeal artery is particularly important. It originates from the maxillary artery, enters the cranial cavity via the foramen spinosum, and runs in grooves along the inner surface of the temporal and parietal bones. The artery lies directly beneath the temporal squama, which is one of the thinnest regions of the skull. If a pin penetrates this area, it may lacerate the MMA, leading to an epidural hematoma. This is the classic talk and die lesion seen in head trauma, where patients may initially seem fine but rapidly deteriorate as the hematoma expands. For this reason, pinning over the temporal squama should always be avoided. Finally, the occipital artery. This vessel is another branch of the external carotid artery. It runs posteriorly deep to the sternocleidomastoid muscle and then ascends with the greater occipital nerve to supply the posterior scalp. At the level of the superior nuchal line, it becomes more superficial and vulnerable to pin-related injury. Complications include hematoma formation, pseudoaneurysm, and even chronic occipital pain, often due to combined injury of both the artery and the greater occipital nerve that courses nearby. When placing Mayfield head holder pins, you must always keep in mind the major arterial structures of the scalp and skull, as injury to these vessels can lead to significant complications. The dural venous sinuses are some of the most important structures to keep in mind when applying the Mayfield head holder. They lie just beneath the inner table of the skull, and accidental penetration during pen placement can result in massive bleeding, venous hypertension, or even air embolism. Let's start with the superior sagittal sinus, or SSS. It runs in the midline, within the superior margin of the falx cerebri, exactly along the sagittal suture. It extends from the crista galli anteriorly all the way back to the confluence of sinuses at the occiput. If a pen penetrates this region, it can lacerate the sinus, causing profuse venous bleeding that is very difficult to control. Because venous sinuses are non-collapsible, there's also a risk of venous air embolism, particularly if the patient is in the sitting position. In severe cases, sinus compromise can lead to cerebral venous infarction. Key teaching point: never place pins in the midline. Safe fixation zones are the paramedian parietal bone, away from sutures and venous grooves. Next, the transverse sinuses. These run horizontally from the confluence of sinuses along the occipital bone at the attachment of the tentorium cerebelli. They course laterally toward the mastoid region. In some patients, the overlying bone here can be extremely thin, which makes it vulnerable. Pinning too close to the lambdoid region risks puncturing the transverse sinus, leading to venous hemorrhage, venous hypertension, and possible air embolism. Next are the sigmoid sinuses. These are the continuation of the transverse sinuses curving in an S shape inferiorly toward the jugular bulb at the jugular foramen. They lie directly beneath the mastoid portion of the temporal bone, an area that can sometimes be mistakenly chosen for pin placement. If violated, the result is massive venous bleeding, with a very high risk of venous air embolism and significant disruption of intracranial venous drainage. In short, the mastoid region is an unsafe zone for pins. The bottom line is that venous sinuses, while not visible externally, must always be respected. Avoid the midline, avoid the lambdoid and mastoid regions, and always choose safe paramedian parietal bone for secure fixation.
Another critical anatomical consideration when using the Mayfield head holder is the network of emissary veins. These are valveless venous channels that pass through small foramina in the skull, creating direct connections between the extracranial veins of the scalp and the intracranial dural venous sinuses. Because they lack valves, blood, and even air can flow in either direction depending on pressure gradients. This has two important consequences for pin placement. 1. They create natural weak points in bone. Pins placed directly over foramina may not seat securely, leading to unstable fixation. 2. They serve as conduits for air embolism and infection. If injured, especially in the sitting surgical position, these veins can entrain air into the venous system or transmit extracranial infections intracranially. Let's review the key emissary veins and their associated foramina. Parietal emissary vein. It passes through the parietal foramen close to the sagittal suture. It connects scalp veins with the superior sagittal sinus. Clinical relevance. A pin placed too close to the midline parietal region can injure this vein, leading to venous bleeding or air embolism. Mastoid emissary vein. It runs through the mastoid foramen, located posterior to the mastoid process. It connects the posterior auricular or occipital veins with the sigmoid sinus. Clinical relevance. Injury here can cause massive venous bleeding, air embolism, and even serve as a route for infection spread from scalp to brain. This is one reason why the mastoid area is considered an unsafe pinning zone. Condylar emissary veins. They travel through the condylar canal near the occipital condyles. They connect the vertebral venous plexus with the sigmoid sinus. Clinical relevance. Though less commonly encountered, posterior pinning near the foramen magnum may compromise this venous route, risking bleeding or air entry. Occipital emissary vein. It passes through the occipital foramen near the external occipital protuberance. It connects the occipital vein with the confluence of sinuses. Clinical relevance. Posterior midline pin placement risks injury here, with potential for bleeding, venous hypertension, or air embolism. Key teaching point. Always avoid pin placement over emissary foramina and venous channels. These are not only mechanically unstable sites, but also potential gateways for life-threatening complications like venous air embolism. Careful palpation and preoperative imaging help in identifying safer zones away from these vulnerable regions. When applying the Mayfield head holder, understanding skull thickness is crucial for both safety and stability. In adults, the average skull thickness ranges between 4 and 7 millimeters. The parietal bone is the thickest and most uniform, making it the safest and most reliable area for pin fixation. The frontal bone is also thick, but we must be cautious anteriorly because of the frontal sinuses. The occipital bone is thick as well, but proximity to major venous sinuses makes it a higher risk zone. Pins are designed to penetrate only the outer table, about 1 millimeter deep, which provides secure anchoring without violating the diploe or the inner table. The frontal eminence, parietal eminence, and external occipital protuberance are preferred sites for fixation. In pediatric patients, things are very different. Their skulls are much thinner, often less than 1.5 millimeters before the age of 6. The bone is soft,
Sutures are unfused, and in hydrocephalus, the calvaria may be even thinner and stretched. This increases the risk of complications such as depressed fractures, dural tears, or epidural hematomas if adult pins or torque settings are used. That's why pediatric pins, which have blunter tips and lower torque, must be applied. The key takeaway is, in adults, aim for the parietal region for the safest fixation, while in children, use great caution with specialized pins and lower torque settings to avoid serious complications. In summary, safe application of the Mayfield Head Holder depends on a solid understanding of the relevant anatomy, including scalp layers, sutures, vascular, venous, and bony structures. We must always avoid danger zones, such as the midline where the superior sagittal sinus lies, the temporal squama over the middle meningeal artery, the frontal sinus, sutures, and emissary foramina. The parietal bone remains the safest and most uniform site for pin fixation. In pediatric patients, the skull is thinner and more pliable, with unfused sutures and higher risk of complications, so pediatric pins and lowered torque should always be used. Ultimately, good anatomical knowledge ensures secure fixation, reduces complications, and improves surgical outcomes. If you found this helpful, please follow @StudyNeuro for more neurosurgical insights. Don't forget to like, comment, share, and subscribe. Thanks for watching, and stay tuned for more.